Now we can go over the prophylactic medication or preventative migraine medication, and that comes in basically three categories. You start with the generics. None of these were actually made to prevent migraines. They were medications that had another primary indication, and then it was just found that they did prevent. And then there's CRGP inhibitors, and then there's IM and IV options. And just real quick before we move on, the fastest acting triptan that I mentioned was rizatriptan. That's the fastest acting and the one that you can do at 6 years old. And IV Keppra is the main infusion that you might use, and MDP stands for Medrol dose pack. So this looks complicated, but really you've got your triptans and CGRPs is the primary two that you want to keep in your brain, and then the primary prophylactics are pretty much the same, like a generic and then a CGRP. But specifically the three generics that help are beta blockers, metoprolol, and propranolol. Metoprolol has more sedation to it, so you might use it at night. Propranolol, you can also use for anxiety and stage fright, but the migraine dose of propranolol is a very heavy hitter. It's the 80 milligram extended release twice a day. So you've got metoprolol or propranolol, either one. I usually use propranolol just because of patients are usually super anxious like my anxious migraine patients, I'll use propranolol, but once I have difficulty sleeping, I might use the metoprolol. Propranolol, and you want to just be mindful of if they're on any other antihypertensives. This might actually just benefit that. You can use multiple antihypertensives, but beta blockers could cause some erectile dysfunction, obviously can cause some sedation, and for cardio or peripheral vascular disease, you definitely don't want to use a beta blocker. Then we've got amitriptyline, which helps with our moody patients that also need to sleep, and our topomax is nice for patients that also want weight loss, because topomax does help to suppress the appetite. It's an anticonvulsant that blocks sodium channels. I had a patient tell me they refuse to take topomax because of the extremely low risk of kidney stones. There is a risk of kidney stones, but unless you have a family history, there's no reason to think you would have a kidney stone. Especially if you're a migraine patient, you should be drinking 2 liters of water every day, like your life depends on it. So there should be no need or concern for kidney stone, but that's a thing. Then you've got your CRGP monoclonal, it's not really an inhibitor, it's a monoclonal antibody. It literally breaks down the CRGP protein, and that is Emgality, AImovig, and Ajovy. Emgality I always start with because it has the broadest indications. It's the only therapy that is approved for cluster headaches. So AImovig comes in 120 dose, but for a cluster, you can take 3 doses at a time. So you'll actually just prescribe that 360 dose. And you would do it once every 3 months for a cluster migraine patient, which I haven't gone into the types yet, but cluster migraines are so rare, it's almost worthless to even know that they exist. You will probably never, even as a neurologist, see a true cluster migraine patient, so just keep that in mind. But Emgality is approved for cluster migraines, but the actual dose is 120, but you want to do a loading dose initially, so you'll do 240 initially. If I were you, my recommendation would actually be to start with Ajovy, since it's only 1 dose and you don't need a loading dose. Emgality, because we have so many samples in the clinic, we'll just give them the loading dose right then and there. We also can see if they have any reaction, because really the only side effects to these monoclonal antibodies is a severe anaphylactic reaction. So then in that case, you just call 911. But the side effect profile with any CRGP active medicines is very low, but the AImovig tends to have some constipation associated with it. So for our older patients, which again, people tend to age out of migraines, but if you do have an older patient with migraines, the AImovig is going to worsen their constipation, potentially, not for sure, but that's kind of unique to AImovig, whereas Emgality, that one can be used for clusters. but you have to do the loading dose, which can get confusing for patients. And then Ajovy is the longest acting one. So these are all once a month injections, but a lot of patients will say that weeks 1 and 2 are great, and then weeks 3 and 4 they start getting more and more migraines. So that patient, you want to try Ajovy, and then a lot of times insurance will cover a refill on day 25 for any of these. So if they're that person that it starts to wear off in that final week, just advise them to pick up on day 25 every time and keep track of their pickup dates so that they can get coverage, and there's just a little bit of overlap with that. There is an oral version of this now, or it's really not a monoclonal antibody because those don't come in orals, but there's basically an extended release CRGP antagonist known as, what's the name? It starts with a Q. Qulipta? Yeah, Qulipta. Name brand only right now, and that's every day. And we've got plenty of samples of those, and usually you'll give them that. The sample comes in 4, and then we'll give them a couple of those so they can use it all month. The Qulipta reps will actually pressure you to take Qulipta and their injectables, which is a little bit redundant in the way they work. Of course, this breaks down the CRGP, and this just blocks the CRGP receptor. But insurance will never cover 2 preventatives. So you have to try these just for insurance purposes. And a lot of times I'll just write the contraindications for these because, like, a patient has fatigue, so contraindicated for propranolol and amitriptyline, and then I'll just say, like, concern for kidney stones, so no topomax, and then I'll just go to the good stuff. Like, I wish I could just start with CRGPs for both abortive and preventative. That would be the most medically effective thing to do. We're just playing with insurance, doing all this other stuff. But for, again, simplicity, start with Ajovy, and you can fill on day 25 if they're still getting breakthrough, or you can switch to Ajovy if they're on AImovig or Emgality, and you want like that last final week to not have as many migraines. Other things to consider is the way that these pens work is all different. I think Emgality, it's the same pen as Trulicity. So if they have diabetes and they already use Trulicity, it's the same exact pen. AImovig's pen I find a little bit weird to use because it doesn't have a push button. It's like an EpiPen, but anyway. Then you've got your IM and IV options. So intramuscular is Botox, and IV is Vyepti. Vyepti is just a monoclonal antibody infusion. Vyepti actually was around before these. So really now that we have these, Vyepti seems less appealing to me because you have to go to an infusion center every 3 months for 4 hours to get this done when you could just take a pen home and do it really easily yourself once a month. These do need to be refrigerated, and you don't want to shake them, so advise patients not to keep them in the refrigerator door where it gets shaken around because that'll break down the activity of the product. And heat will also break down the activity of the product, but you can thaw it for like an hour before you use it, just so that it doesn't sting as much. The colder it is, the more it's going to sting. You can put them in any fat pads, so the stomach, the thigh, the butt, the back of the arms, but it's harder for patients to get the back of their arms, so typically they'll just use the stomach. And that's it for now.